My name is Ngozi Iranya, and I want to welcome all of you for joining us in this very important conversation, very timely, and as far as I know of, the first of its kind at this national level as we talk about dementia in the Black community, a conversation that's been long overdue, given what we know is happening within our community. I want to preface a few things before we get started. Number one, I want to preface the language that I'm going to be using. I'm saying Black communities, a Canadian perspective, understanding that the term Black can be contentious for some. As we understand our community, it's African, Caribbean, Black, Canadian, and others. So for the context of this conversation, I am going to be using the word Black to refer to all of that, not as an absolute, but just for our conversations and our purposes for here today. I want to just also preface this conversation with trigger warnings. We are going to be talking a lot today about some very emotional and deep topics and conversations. People are going to be bringing up their own personal experiences. For some of us on the call, maybe bringing up their personal experiences. And so I want to honor that and say that this is a very safe place, a very safe space for all of us to feel whatever emotions that want to come up. Please do take the time to engage with them, step away if you need to. That is perfectly okay. I also want to say that the order in which we want to have this conversation today, I actually had a colleague of mine tell me recently, she said, Ngozi, you're in your auntie era. I didn't quite know what that meant until I found myself wearing my African wrap and cooking for people. And I was like, yes, I guess I'm in my auntie era. And so in honor of that, I wanted to have this conversation as you would with our aunties at the dinner table on Sunday evening, you know, after all the cooking and washing and cleaning is done. And the aunties get together and we share our stories and we share our feelings and we share our thoughts and our knowledge. And that's how we share our knowledge and that's how we keep our community growing and strong. So in that tradition, I would like to have this conversation today as we talk about dementia in the Black community. I wanted to also let you know that in the beginning, I'm going to have a bit of an introduction to dementia and an introduction to Black Canadians in the Canadian space. I think it's important that we contextualize this conversation with a lot of background information and background determinants as to our health and how our health is impacted with dementia and these other determinants. But before I do that, I would like to introduce our wonderful panelists. I am grateful and heartened that these wonderful women can join with us and share their knowledge, their expertise, their heart, their grace, their compassion, and their passion for this topic. So I'll begin, and if you could just say a little wave as I go through your names. I'm going to be giving just a highlight of their names and their positions. There will be a link in the chat to their bios for those who want more information. So our first panelist is Dr. Mireille Norris. She is the assistant professor in the Temerty Faculty of Medicine at the University of Toronto. She is also a geriatrician at Sunnybrook Hospital in Toronto. Thank you, Dr. Norris, and welcome. Thank you. Our next panelist is Dr. Claudette Holloway, RN. She is the executive director of the Jamaican Canadian Association of Nurses in Toronto. She has a wealth of experience, a wealth of knowledge on this topic, and we are so heartened and welcome that you're here. Thank you so much, Dr. Holloway. Our next panelist is Yvonne Appa. She is a nurse practitioner in continuing care, and she's a faculty at MacEwan University in Edmonton, Alberta. Thank you, Yvonne, for joining us all the way and very early for you. So thank you for joining us. I know it's very cold over there and very early, so thank you for coming. We also wanted to welcome Rose Fraser, retired community nurse and lifetime board member at the Health Association of African Canadians in Halifax, Nova Scotia. Thank you, Rose, for joining us. Very wonderful to have you here. Thank you so much. You have a wealth of knowledge we can't wait to tap into. Mary Lakindu, she was on our panel as well. She's a program coordinator at Promoting Leadership in Health for African Nova Scotians at Dalhousie University. She unfortunately is not able to make it today, so we wish her well and we hope to see her again. But here is our panelists, and from here we are going to discuss dementia in the Black communities here in Canada. Dave, if I can just ask you to start the presentation, that would be amazing. Thank you so much. And so I wanted to begin the presentation. Some of us on the call, I do recognize that some of us on this call are healthcare practitioners, researchers, academics, but there's also a swath of people on the call who are new to this conversation and who might be scared of this conversation. And so to bring everybody up to the same curve, I wanted to just go through some preliminary sort of Dementia 101 with everyone and some more contextual information, as I said. I wanted to start off with this picture of myself and my papa, Felix. There's a story that I'm going to weave through this conversation as we discuss the story of my father, Felix. He is a Nigerian immigrant to Canada, came here in the 1970s. So he got dementia in 2007. He was diagnosed with it. And so I wanted to introduce this because I wanted to let people know that this does happen in our communities. Oftentimes when we hear about dementia in the Black community, we kind of take it in this abstract kind of out there kind of form. And so I wanted to bring it a little bit closer to home for us so that we can really engage with this conversation, this material as we move forward. And I'm going to ask Dave for the next slide, please. Thank you so much. Okay. Sorry. So when we talk about dementia and we ask what is dementia, dementia itself is actually an umbrella term. Dementia is not a specific disease, but it's rather a general term that we use for the impaired ability to remember, to think, to make decisions, and that can interfere with our daily life and with our health status as well. There are multiple forms of dementia. Alzheimer's is the most commonly known, the ones you would hear the most of, but there are other forms. Lewy body, vascular dementia, frontotemporal dementia. Bruce Willis was just released a public statement last week about his diagnosis with that. And there are a couple of other forms of dementia. Most dementias are progressive in that it does advance and get worse, but life does not end at diagnosis. So if a diagnosis does happen, it does not mean that all is over. With an early diagnosis, there are appropriate interventions and modifiable risk behaviors that you could do to delay the progress of the disease. And as well with some risk modifications, you can actually delay the onset of dementia. We'll talk about that a little later on as well. Can I have the next slide, please, Dave? And so when we talk about dementia being a general term, it means that symptoms can also vary widely from person to person. But in general, people with dementia do have problems with their memories, their attention, communication. Sometimes their communication can be repetitive in nature. It can be stagnated in nature. It can also have missing gaps in being able to communicate in terms of sequence of words. There's also reasoning impairment, judgment and problem-solving impairment. The visual perception can also factor into this as well issues with movement and mobility. I also want to say there's also sometimes issues with behavior and mood. Sometimes people with dementia in the early stages can have a mood change or behavioral change, which could mimic something like depression or aggression, but that can also in fact be a symptom of dementia. Can I have the next slide, please, Dave? And so while we talk about dementia, we do talk about it sort of in the context of the age, senior population, but I want us to be very, very clear that dementia is not a normal part of aging. So it's not that as you start approaching a certain age, you're going to think to yourself, I'm going to get dementia. Dementia is not a normal part of it. And in fact, there's a condition called young onset dementia that is increasing, especially in certain ethnic and racial groups. Young onset dementia is when dementia is diagnosed in someone under the age of 65. There have been reports of people as young as in their 40s and 30s also getting a diagnosis of dementia. And just recently, I believe there was a teenager in East Asia who was diagnosed with dementia, a form of dementia, and they are 19 years of age. So I want us to really be able to think broadly when we think about dementia, that it's not just regulated to, grandma in the corner and, but it can happen, to anyone at any point. As we talk about dementia, I want us to be also very clear that dementia does affect, yes, Satine, dementia also does affect many, but dementia does not affect everyone equally. So, when we think about dementia and dementia care, I've had conversations with people that have said to me, oh, dementia care, dementia is horrible for everyone. And it is for the most part, but some groups unfortunately experience dementia a little bit worse than others. We're going to talk about that. Can I have the next slide, please, Dave? And so our conversation today is about dementia in the Black community. And it is a conversation near and dear to my heart, as you know, and for many of us on the call who have joined with us as well, either in our own families or in our friends or in our colleagues or neighbors, et cetera. And how we understand dementia in the Black community, I think we need to understand a little bit more about the Black community in Canada before we do that. And so I wanted to just give us a little bit of some statistical background information. So as of 2021, 1.5 million people in Canada identified as Black. That's 4.3% of the population. That is actually up from 3.5% that we saw in 2016. So our percentage of the population makes up about 16% of the whole racialized population in Canada. So our numbers are increasing, and to that, projections for Black populations means that by 2036, we're looking at 3 million people, 5% of our population, and by 2041, that's about 3 million people. And when we think about how time moves very quickly, that's not too far off from now. And so I say these numbers for us to begin thinking about with this population on the increase, how can we prepare? How do we plan in a more preventative way to support these individuals with their healthcare needs as they're coming to Canada? Can I have the next slide, please, Dave? Thank you so much. Sorry, I'm trying to get my slide here on my screen as well. And so when we think about these numbers here, I just wanted to give more of a visual here. So as we see here, this is where we have our visible minority population in Canada. The Black population is right here, 16% of it. Here is a period of immigration, and here we are 2016 to 2021. We're just moving on a little bit further up now. Now, I want us to also know that the statistics sort of, I want to say, start at 1980. This is, they have before 1980. There's obviously more distinguishable information there, but some of us on the call may know or understand, or may even be a part of this generation that came to Canada in the 1960s and 50s on different work programs, which, you know, really was the beginning of the increase of the population that we see now. Can I have the next slide, please, Dave? And so I wanted to also say that our Black communities in Canada are not a monolith. We are not all the same. There's over 300 different ethnic origins in Canada who identify as Black. Over 25 also report more than one ethno-cultural group. And there's over 450 languages spoken, which is phenomenal. In addition to the 59% that speak English and 21.6% that speak French, there's also 450 languages as a mother tongue. Nearly 1/3 of Black immigrants, as 2021, were born in Africa. The 3 most popular countries where they came from was Nigeria here, Ethiopia up here, and the Democratic Republic of Congo. 21% of newcomers to Canada who identify as Black were from the Caribbean, and the largest source countries in the Caribbean were Jamaica here, Haiti here, and Trinidad and Tobago here. So there's a multiplicity of cultures, of languages, of ethnic backgrounds, religions, as we understand the Black community here in the country. Can I have the next slide, please, Dave? And so when we think about where we are in Canada and where we are located, this is sort of a map of where the Black population is distributed throughout the country. We will see here that Ontario has the largest population of Black populations. That's, you know, from most populations in Canada, Ontario is the final destination for many. But we do see Manitoba also has a significant population as well. I'm not able to read properly. That's 46,000, excuse me. Alberta, Quebec as well has significant populations. Fun fact, the prairies are actually a growing destination for Black population newcomers to Canada. So that's very exciting to see that as well. Nova Scotia has the oldest settlement for Black Canadians in the country as well, which makes it a very important, not just historically, but also culturally and socially and economically for the country. So this is just a typography, so where we can see where we are situated throughout the country. Next slide, please. And when we think about it from a city perspective, here are the Black population that's distributed by major cities in each province. We will see here that Toronto and Montreal have the biggest populations, and then Calgary as well. Ottawa is not on this list, but Ottawa also has a significant population for Black Canadians in the country. Next slide, please. Thank you. And so when we talk about dementia in the Black community, it's always interesting to see what the research says. And unfortunately, there's an unfortunate truth that in Canada, there is a very significant lack of research on the experiences of Black Canadians on their dementia journey. So it's very important that we know what is happening within our communities if we are to develop the right programs, the right policies, the right supports for our communities. But without that knowledge, there leaves gaps in the ways that caregivers can provide support, the way that healthcare practitioners and the healthcare system can respond adequately and continuously for the population, especially as we increase in Canada. But we have seen some trends though. When we look at research from the US and the UK, we have seen some consistent trends for Black populations and dementia, even though they're on other sides of the pond. We can speak to that a little bit, and then we're going to speak to more overarchingly some social determinants around dementia. So one thing we have noticed in the research is that there's a higher prevalence and incidence rates of dementia than in white populations, which means that Black populations experience dementia. And I have seen studies that anywhere from 2% up to 100%, in terms of difference, that Black people would experience dementia more than white populations. Black populations are at a higher risk for developing modifiable risk factors for dementia. And I spoke earlier about risk factors for dementia and what that could look like. So things like smoking, things like obesity, things like stress, things like exercise, things like hypertension, high blood pressure. All these things are modifiable through diet and exercise, but we're going to talk about why that might be a little bit problematic within the Black population, but we are at higher risks for developing such health conditions, which then contribute to more risk for dementia. Black populations are also often diagnosed later in the dementia journey than earlier. And this is for a variety of factors. And I call it inside and outside factors. So from an inside factor, from within the population, there is a stigma around dementia within the Black population. People who develop dementia can often be stigmatized and or ostracized from the community and or families, which can lead to a delay in diagnosis. And on the outside of that, there is the healthcare system. The healthcare system, and I'll be very blunt in this conversation, being discriminatory to Black people, especially elder Black people, if they present with dementia-like symptoms, which can put people off. There's also a distrust in the healthcare system, in the formal healthcare system within the Black population, which can make one hesitant to get a diagnosis should they be experiencing something or seeing something in their loved one. And this last one here, which really broke my heart in all honesty and transparency as I was reading up more about it. Black populations experience premature aging of the brain due to weathering. Now, weathering is a hypothesis that prolonged exposure to stresses, and in this case, notably discrimination and racism, can have an effect on the brain, which can lead to it aging. And we're going to talk a little bit more about some of the physiological changes that happen. So these are some of the things, some of the trends that we have seen in the US and the UK regarding dementia in the Black communities. And we should very much have this as well in Canada. We should have our own body of research around this. So let's continue on. Can I have the next slide, please? Thank you, Dave. So as we talk, and forgive my eyes, I have two screens going, so I'm going to be checking out this way. As we talk about dementia, there are certain risk factors that I wanted us to talk about or bring to our attention as we move forward through this conversation. And these are, there are more risk factors than this, obviously, but these ones are the ones that are really poignant and really stuck out to me, because this was a lot of the conversations that I heard with people when I spoke to them about dementia. They would say, well, what about housing? And I don't have a good enough job and I need money, and these sort of contextual features around their ability to even acknowledge their dementia journey or really, support themselves or loved ones on their dementia journey. So let's talk about housing within the Black Canadian context. So according to the 2016 census, the Black population had a home ownership rate of 40%. Compared to the national average of approximately 70%. So there's a huge disparity there. This was in 2016. Those numbers have not increased significantly in the 2021 census. In 2021, 26% of Black Canadians lived in unsuitable housing compared to 9.7% of the population. Now, unsuitable housing means that you have one room, basically not enough rooms for the amount of people you have in your household. Also to that, 33% of Black people lived in homes that needed major repairs, and 26% were in need of lived in homes that needed minor repairs. So when we think about this, we think about lack of home ownership, we think about inability to have suitable housing compared to the general population, and we think about, you know, where repairs are needed in that housing and that effect that could have on someone's health status mentally and physiologically. The next one is education as a determinant. So 32% of Black Canadians hold a bachelor's degree, which is amazing and wonderful. 11% hold a master's degree, and they were very, and about, I want to say 9% hold a completed PhD. Now, again, as we talk about the variations in the Black population in terms of ethnicity, there's also variations seen in the education attainment within the Black populations. Some subsets of the Black population attained higher education levels than other subsets, which is very important to know. Third generation Canadian, Black Canadians had, I think, one of the least amount of educational attainment as opposed to first generation from Africa and Caribbean islands.
Correct.
One thing to note as well, despite the education that Black populations have achieved, there is an overqualification at their jobs, such that if you have attained a bachelor's degree or a master's degree, we saw that 16% of Black populations were doing work that required less education. Now, this is significantly higher than the general population that was overqualified at 11%. So again, we see that disparity in terms of educational attainment and what that looks like in terms of outcome, in terms of gainful employment. Now, and this was seen despite the foreign credential sort of conversation. We say, oh, you're from abroad, so your credentials aren't really counted here. You need Canadian experience. Despite that, we still have this disparity. And notably, first, second, and third generation Black Canadians all experienced on average 15% of them being overqualified for their jobs. So these are just, again, some contextual information for us to think about. When it comes to employment, so on the similar sort of vein, Black Canadians experienced higher unemployment rates than non-visible minority Canadians in the recent past. 12.5% of Black Canadians were unemployed as the 2016 census, compared with 6.9% of non-visible minority population. So almost double the amount of Black Canadians were unemployed as per 2016. Now, with the 2021 data, I did speak to Stats Canada, and they did send me some information. They haven't compiled it yet. That will be coming out throughout the year, I was informed, but they did send me some more data, so maybe I can put that together and send that out to people who, if those are interested. I will say at the end of the 3 months in January 2021, the unemployment rate among Black Canadians was about 13.1%, which was about 70% higher than among the non-visible minority Canadians. Black youth experienced very high unemployment, especially during the pandemic. Almost 1/3 of the labor force in this group, 30.6%, was unemployed in January 2021, almost twice the rate of non-visible minority youth. Now, also 1/3 of Black women were employed in the healthcare sector when we think about the pandemic, when we think about who were the PSWs, who were the nurses, who were providing the frontline care. And all of this is, again, being contextualized as when we situate ourselves within the Canadian landscape and how all this information lends itself to our healthcare and our dementia journey as caregivers or as those living with dementia. When we think about income status, So income status, this is sort of, again, very high level. There's more information on Stats Canada. I can compile some more as well. Black Canadians had an average employment of $39,240. Medium was $31,000. Black men out-earned Black women. Black men out-earned Black women at $42,200, and Black women were earning $36,640. Now, the national average for all visible minorities was $50,280. So if the national average, if the average for Black Canadians was $39,000 and the average for visible minorities was $50,000, there's a disparity there. The national average, though, for employment income, as I found it, was $54,200. So just again, when we think about the ways in which our income, our employment, our housing, our education impacts our ability to make the best choices for ourselves and our loved ones on the dementia journey. The last risk factor that I want to talk about is discrimination. And this one is also very near and dear to my heart. I've worked in healthcare for 20 years, and I've seen, as many of us on this call have seen, a lot. In Canada, as much as we want to say that we are multicultural and we want to say that we are very inclusive, we still have a long way to go. We're not as bad as we have been, but we're not as good as we could be. And so this is to highlight some of those pieces. And so when we talk about anti-Black racism, there's a specific form of racism when we talk about racism, the anti-Black experience. And the anti-Black experience is global, as we have seen in the past few years with events of police brutality on Black bodies. It's a very specific form of racism, systematic forces, microaggressions, and interpersonal encounters that can have deep impacts on our dementia journey and our brains. I wanted to talk about how this affects our brain. People say, oh, it's, you know, it's a bit of a microaggression. If someone's racist, just get over it, move on, and you know, all will be well. But the studies have shown that there's a correlation between stress and cortisol, the stress hormone, and the impacts on the brain. There have been recent studies that have shown the effects of racism on the brain, affecting factors like global cognition, poor test performances involving episodic memory, as well as structural changes in the brain. One of those structural changes is the instances of reduced cortical volumes, smaller hippocampal volumes as well. And these are associated with major events of racism. Progressive white matter pathology, which is white matter hyperintensity associated with everyday racism. So what we're finding is that the more exposure you have to racism, either big events or these small incremental everyday events, actually can reduce the amount of which your brain can hold. It can reduce the transmission of signals in between the brain regions, and that can obviously impact your cognition. That can obviously impact your memory bank as well. And so when we think about it from a Canadian perspective, I know in Canada, when we talk about discrimination, it can be a little bit of an awkward conversation, but these conversations need to be had if we want to really move forward. In 2019, the General Social Survey on Canadian Safety found that 46% of the Black population over 15 had experienced at least one form of discrimination in the 5 years preceding it. So from 2014 to 2019, people have said they experienced at least one form of discrimination. And this is compared to 16% for non-Indigenous, non-racialized individuals. So 46 compared to 16. Again, a huge disparity that we saw there. When we talk about discrimination, we found that it was more common among Canadian-born Black populations as opposed to immigrants. And this was mainly seen in everyday settings. So in banks, restaurants, stores was where people felt forms of discrimination. This is not to exclude that which you'll see at your workplace, with your neighbors, and certainly within our healthcare system. There was also commonalities with facing discrimination within law enforcement and engagement with law enforcement. Reported discrimination was 4 times the amount with non-racialized and non-Indigenous people, who were experiencing at 16%. Our Indigenous brothers and sisters, they had higher reports of reported discrimination with the law enforcement system at 21%. So these are just some information and some notes for us to think about when we contextualize how we move through Canadian society, and how the Canadian society moves with us is how we understand how we can really approach our health status as we think about dementia as we progress. Can I have the next slide, please, Dave? I'm so sorry. So before we continue, or before we close off, I want to talk about intersectionality. And intersectionality is a buzzword that many of us have heard about. For those that have not heard about it, intersectionality is a term coined by Kimberly Crenshaw, really also advanced by Patricia Hill, two wonderful Black feminist scholars, looking at the ways in which multiple social identities coalesce together to form your whole personhood. And so I'll use myself as an example, I am a Black woman of a certain age, I'll never say, of a certain education level and a certain class level. My whole person is then engaging with systems of power. And when we talk about intersectionality, we really have to talk about themes of power, because that's how this term was coined, and that is the study in which it was developed from. And so when we look at the whole person, and when they engage with the healthcare system, for example, how are they then thus treated as their whole person? When I go to the healthcare system, I'm not just seen as a woman or as a Black person. I am seen as a Black woman of a certain age, of a certain social status, and all of that features into my care model and how I'm treated. And so when we think about and extend this to other identities, race, gender, and class typically are the three, I want to say, more common identities that are evoked when we talk about intersectionality, but there are several others: LGBTQ, sexual orientation, migration status, right? If you are a newcomer to Canada, if you have an accent when you're here in Canada, or you first, second generation, your religion, your abilities, all that plays into the ways in which the healthcare system and social services systems is able to then meet your needs, or even identify what your needs are. This also plays into your income and employment level. So I always use the example of, in this case, a Pakistani grandmother will go into a hospital, an emergency room, not speaking very good English, perhaps, and their granddaughter or son is there with them trying to translate, and they're experiencing symptoms of what could be early dementia. How would that grandmother be treated? How would they be seen? How would they be approached? And all of the intersections come into play at that moment. One thing also to consider is the life course. When we think of dementia as affecting older people, though it's not exclusive to older people, we think about the life course that got them to that point. What was their education, their employment, their family dynamic, their housing situation? All of that features into the way in which their body has moved through life and how their body is going to then respond when it comes to dementia. Can I have the next slide, please? So the question then is, where do we go from here? With all of this information and all of this context that we have now discussed when we're talking about dementia in the Black community, when we're talking about the Black community within Canada, what do we do? Where do we go? And from here is where we're going to have our conversation. From here is where we're going to begin to explore this more and to hear the stories of those that know and those that can guide us into doing the right way, the right thing. So thank you for your time and attention of my presentation. Let's begin our conversation. Thank you, everyone. Forgive me, I am not computer inclined. I think by now I developed a visceral allergy to anything electronic. So before we begin, I want to let us know that our conversation is going to be broken down into several sort of pieces. The first piece we're going to be talking about is the perception and stigma around dementia. Sort of what does that look like? I want to take us on a journey, right? I want us to understand sort of dementia from the beginning to end and how we can see ourselves in it, how we can see those that we love and care about in it, and how we can best support them as practitioners, as caregivers, and as ourselves. So I invite all of our panelists to unmute themselves if possible. These are going to be open questions for everyone, and it's going to be aunties together. I have my cup here. We can sit and be comfortable here together. So the first question I want to ask about, in your experiences, when we think about dementia, how have you found that the perceptions of dementia have been within the Black community as you've treated people living with dementia, maybe in conversations, in your community work? What have the perceptions been like? What have the conversations around stigma and perceptions? Anyone, please? Yes, go ahead, Dr. Norris.
As you know, I'm so passionate about this, and thank you for all the data that you share. And my middle name is Emily, like my grandmother who lived with us, who had dementia at the end of her life. So I'm very passionate about this. So I think, the word dementia means that does not have mind. So right away, the term is emphasizing the deficit. So now the word has been changed for neurocognitive disorder major in the context of loss of function, such that, in the Black community where, certainly I come from the Caribbean, Haiti, and tremendous veneration for our elders. And, when an older person from Haiti has met 98 years old, I like to say that's like 120 in Canadian years. So culturally, we want to focus on the person that we love, the personhood. And when the diagnosis focuses on a deficit of memory, it diminishes the person. And what I observe as a geriatrician is, dementia, the memory problem is a handicap. It's something that can be remedied. It's an ability that can be helped with resource, with family disclosure. I was a physical therapist before I was a physician, such that we can turn the light towards abilities as opposed to emphasizing the deficit. It's important to know what the deficit is so that we can palliate it, so that we can remedy, so that we can, offset it. So I think this is where there's quite a difference, where sometimes there can be a conflict with a healthcare system that wants to emphasize the diagnostic criteria and the deficit, as opposed to honor the whole person that we love.
Wonderful, thank you. That is absolutely true. I'm thinking, I want to go over to you, Yvonne. Do you have any thoughts in terms of your work that you've seen?
Well, one of the big pieces is that I work in sites for congregate living, so long-term care homes, assisted living homes. And one of the primary things that I picked up when I was thinking about this was that I don't see a lot of Black older adults or Black individuals with dementia in the homes. There's a lot of disproportionate representation of people that are Black with dementia or with cognitive impairment. I often find that the conversations I have with their caregivers are more leaning towards that they feel like there was a failure or there was an inability to do good for their loved one, and that this was a last resort. So you wonder how they're faring out in the community when they come in very late stages. So that's what I encounter mostly, but I also encounter very few of them. So that it was so surprising, Ngozi, when you told me the numbers, and then I started doing my own research. It's surprising given those people who connect with services such as work that I do as a nurse practitioner. You don't see them very often in these clinics, and you don't see them often engaging in resources that might help support the caregiver. So I do think that there is a perception that some of the issues that happen during dementia, such as memory loss, depression, some of the behavior issues, may be associated with normal aging in our community as well, that it might be a flare of a personality as well. So there's some misconceptions of what this disease looks like, as Dr. Norris is saying, that they don't want to look at it as a deficit.
Absolutely, absolutely. Rose, I know you wanted to say something, some words.
Yes. I would just like to add something that Dr. Norris was speaking of, just in terms of focusing on strength-based treatment rather than deficit, in dealing with a person with dementia. My mother had dementia and died with dementia, with the vascular dementia. And one of the things in my community, I live in a community in rural Nova Scotia. It's the largest historical Black community in Canada. We've been around for between 200 and 300 years. And so I'm a sixth generation Black Nova Scotian. And I've lived in this community most of my life. And what our community perception around dementia is that it's something that we don't talk about. It's something that we need to just ignore. We move on through it. We deal with our loved ones. We do what we have to do as far as caring for them. and we don't put them in a home, you know. So the perceptions around the term, when I think of the term dementia, many of people that I've spoken with and people that I've treated and worked with, the term dementia and Alzheimer's become interchangeable. And so what occurs is that people, just through not having all of the education piece around what dementia actually entails, is they may not know even what type of dementia their loved one has. We found out that our mom had a vascular dementia. And one of the things that I found to be true in the community is that the terms that people use when they saw that their loved one or the family member was changing. Things were changing in their behavior, things were changing with their memory, and they would say things like, oh, she's not quite right, or she's just a bit senile, she's a little bit out of her mind, or she has some timers as opposed to Alzheimer's. And, you know, often there's just no admission of a diagnosis or even insight into an early diagnosis. So it becomes an invisible disorder. It just becomes invisible. And disorder, I don't mean that in the negative. I mean that what has happened in the family is that because someone is experiencing these kinds of symptoms, what happens is that things go off the rail in family. Everybody's affected. And so the perceptions in the community is that, okay, we have to protect this family, we have to protect this loved one, or we have to just leave them to themselves so that they can work it out.
Yeah.
And so yeah, it's and it's becoming more pervasive in our community now than it was, and we're finding younger people within Preston Township, where I live, are being diagnosed with dementia. And so, yes, thank you so much again for the statistics. I was unaware of so many of them, and this is something that we really need to take into consideration very, very soon, because many of us are becoming older. Many of us are showing up with signs and symptoms of dementia, and yeah, so glad this is happening today.
Well, thank you. I so many wonderful points that all of you have said. And Dr. Holloway, I want to check in with you first, and then Dr. Norris, did you want to add, Dr. Holloway?
Just quickly, I agree with what Rose was saying, that that term senility, over my years in our communities, I've heard that, and it was almost, it's like a fracture, a big fracture that had to be hidden. Nobody wants to talk about it. You kind of hide them away, and you know, that's not something that happens to us. So I'm so glad that now these things are more into the open, but there's still a lot more to do.
Yeah, I cannot overemphasize enough the shame that comes along with a diagnosis within the family. If you have a family that's not attuned, so my family's Nigerian background, and I remember my dad got diagnosed, it was 6 years before my extended family wanted to accept it, my aunts and uncles. They kept saying, oh, Ngozi, he's fine, he's fine, and go, don't do all this, it's fine. And we became more isolated, right? Because you can't talk about it. No one's going to be there with you. And the burden that places on the family can be enormous. And there's an element of shame and more, it can set into depression, to be quite frank. And so, you know, being able to break open that stigma and those perceptions can really help not just the people living with dementia, but the family members as well. Absolutely. Dr. Norris, did you want to say something there? I saw your hand up.
Yes. So I'd like to bring the awareness on how all the determinants that you mentioned in your talk and the stigma will lead to delayed in diagnosis. So while neurodegenerative condition itself does not respond very well to medication. There are medications that can slow down the process or alleviate some of the symptoms, and that's evidence-based. There are many medical interventions that can save the brain, delay the deterioration, and those are evidence-based. For example, accessing hearing aid. For example, managing blood pressure. I've had patients come with uncontrolled hypertension in my office, encephalopathic. I optimize their blood pressure. They return to my office with an improvement by many points of their mental status. And then I start a cognitive enhancement drug. And then I add the hearing aid. And then I add the management of sleep apnea and weight loss and optimization of diabetes. And I stop the use of sleeping pills or alcohol, such that the stigma, the lack of knowledge, the difficult access to resource, the discrimination in the healthcare system will lead, unfortunately, to worse outcomes. And unfortunately, we'll have a scenario where families come at the 11th hour, exhausted, in the emergency room where they face more discrimination, an environment that does not meet their need. And then you get in this revolving door situation, crisis mode situation, behavioral issues that are not addressed, the person being labeled paranoid without necessarily understanding the history of intergenerational trauma. And therefore we lose the opportunity of a person-centered approach, such that a talk such as yours, really increasing the awareness in the community, having services targeted to the need of the community, has a chance to optimize the care of the population. Certainly in my experience working with Black social workers and trying to bridge that mistrust, I've had some good success stories. So there is a need for that focused approach.
Wonderful. Thank you. Yes, Yvonne. And then I'm going to go to our next session. Go ahead.
Sure. One of the comments that I was going to make also is that there is sometimes a sense of inevitability of having certain diseases come up. And I know this is not unique to just dementia as well. I was thinking about my time when I worked in New York, and it's a large Black population there. And a lot of conditions that people would come in for acutely, there were a lot of chronic conditions. They would minimize them and kind of talk about the inevitability. So this is possibly something that was likely to happen. It was just, when was it going to happen? So it almost gets a little bit reduced. And I think that the being reductive in these doesn't own that there could be some supports, like Dr. Norris says, early treatment for things to delay the progression of disease, early screening as well. And we look at the risk factors like hypertension, high cholesterol, all those things are risk factors. And, you know, we know that Alzheimer's disease is the more predominant one, but the second one behind that is vascular. And we have so many risk factors in the Black community for that.
Absolutely. To that, I want to just jump off then to the next session is experiences with the healthcare system and social services system. So Dr. Norris, you alluded to this, but I wanted to ask everyone else on the panel as well. In your experience, how do you think the healthcare system has responded to the needs of Black people living with dementia and their families when it comes to supporting their dementia journey? And I think I want us to think about this in the sense of what has been working and what hasn't been working. I think we're all very familiar with what hasn't been working. Let's be honest. We all know where the gaps are for the most part. But let's talk about what has been working, maybe as a way to expand and sort of, you know, strengthening the hand that's been strong, and just sort of overarching more broadly. How do you find how the healthcare system in your jurisdiction or just in Canada writ large, how's it responded? How's it been going? Anyone, Rose, you want to start? I see you're looking kind of like.
Yes, I was just waiting for somebody else to start. One of the things that has been my experience in working, I've been a health professional for 43 years as a nurse. And in those years, what I've seen as a strength, and this is a strength, continuing care, Nova Scotia has been very helpful in the journey when people have loved ones with dementia. And many times we've had to rely on that organization to be the intervener to help as far as getting supports in their home, making sure that they had VON services for their medication distribution, making sure that they had home care to help take care of their personal needs and all of those things. And so they have been a help in the community. But one of the things I just want to add alongside of continuing care is that we also have organizations, Black organizations in our community that do help to support with education in our community in Nova Scotia. Organizations like the Association of Black Social Workers, HOC, of which I'm a board member. There's other organizations that also just to help get information out to the community that's necessary so that they can find the resources and be linked and connected with resources that help them and their loved ones. It's not always been there, as you say. We do know the gaps. I'm just recalling as I'm sitting here and hearing my parents talk in my subconscious about the health services in our community many years ago. We didn't have an actual clinic or health services provided in the clinic in our community until the 1950s. And so prior to that, many people use their own medicines. You know, there was a doctor who used to come up once every month or something like that. There was one doctor that the community utilized as their care provider, and one for a whole community, you know. And I'm just thinking of other things as well. And I see Dr. Claudia with her hand raised there, but I just briefly, how the trauma and the intergenerational trauma that we have experienced as Black women, even. I think about my mama when she talked about working in the homes of white people in the city. They called the program In Service. And, you know, I call it in servitude. It was very difficult. My mother talked about that, how she was treated, how she was demeaned and not treated respectfully. You think about all of that trauma and how that intersects with how a person processes the world around them, and how that adds to the stress that they endure, their health status, how over the years, my mom had heart disease. And so of course, vascular dementia was a reality for her. And so, you know, you see it, all of those things intersecting to create the picture and to create the foundation for dementia. Yeah.
So it really is a person-centered approach with looking at the whole person, their life history, their occupation, and how that impacts. Absolutely. Dr. Holloway, I see you have your hand up. Thank you for your
question. And I didn't mean to hurry, Rose. I just wanted to get that hand up. No worries at all. But I just want to say that as Black communities, we shouldn't be having to shoulder this burden. We need to have our governments play a role, a strong role in funding. We've heard that there's a dearth of research. Organizations such as the Jamaican Canadian Association of Nurses have to depend on small grants, and they did develop a day program that showed a difference in the people that accessed it. But we have to really, we can't deal with pennies here. We need significant money. We know that the federal government donated $200 million just because it's Black History Month, but that's hardly enough. That's divided across Canada. So we really need, while we're working at the front lines and the sidelines, we really need the government to step forward, and policymakers, as you said, Ngozi, as committed allies, not just saying you're an ally, but being committed and doing something to alleviate this problem. We've seen how senior numbers are increasing across the whole population. And then for the Black community, with the added burden over the years that has eaten away at their very existence as they struggle to raise their families, and the complexity of chronic diseases on top of that, you know, we really need to do something. So at least with JCAN, we had a chance to do something with a day program. It was small. We're now doing something else. We want to move it further up the ladder. We're moving it now into, because I came from a public health background just most recently in my career, but we're trying to move it up so that we can be proactive and get ahead of this disease. And therefore, you know, along the way, provide support for caregivers. So we really have to get everybody on board and stop trying to just manage all this ourselves. Let those that are committed allies show their hand.
I wish I could like stand up and applaud you for that. That is absolutely amazing and absolutely true and absolutely necessary. When I think about our demographics of Canada, right? So we're at 37 million people. Of that 37, I think it's 7 or 8 million who are over the age of 65. And then we have, I think, 6 million or 7 million, 0 to 14 years of age. The rest of that is between the ages of 15 and 64 years of age, that population. As we get older, our healthcare needs are going to increase. Dementia or anything else, factors of dementia, it's going to increase. As a government, so I know this call is being recorded and I know people might check in later on, as a government, being proactive as a moral imperative and also as a fiscal responsibility to the country and the people of this country, investing now is going to be more beneficial morally, financially, socially, politically, than waiting to the last minute, right? And so that is a point that cannot be understated. It has to be, you know, shouted from the heaven tops that, you know, funding, political will, political support, and intention is very much needed for our population, all populations really as well. Let's just be clear about that. Thank you so much. I want to move on to the next session because I know we only have like 28 minutes and I can talk a lot. I wanted to talk about end stage dementia and long-term care homes. Now, I understand that in our community, we don't tend to put our folks in a long-term care home. We just don't do it, right? We keep them at home until we can't anymore, right? And there's a lot of shame around that as well. A lot of shame and guilt around people being at home and loved ones not being able to provide the care. Maybe they have younger children and they have demanding careers, or, you know, putting them in a home. There's a sense of failure. I failed, I couldn't do it. What's become of me? They took care of me my whole life. Now I can't take care of them. And so I wanted to talk about that. As dementia advances in people, what are some of the positive things that you have encountered in terms of, you know, this stage, the end stage of dementia? And I'm thinking specifically like what is needed in terms of for caregivers and, you know, in a cultural context way, because, you know, you were talking about, you know, caregivers coming in at the 11th hour, right? Dr. Norris, people are coming in, they're burnt out, it's crisis. What do we do now? How can we talk about this from a cultural perspective at this stage? Because I think a lot of the dementia work that we see in Canada is on the beginning and mid stage, right? Let's talk about prevention. Let's talk about knowledge, information, stigma reduction. Let's talk about managing dementia. But what about the end stage? That last stage that no one really talks about, the not so stage. What happens there?
So I'm sorry, I feel like I've got to jump in there.
Oh, jump, let's jump.
I'm very passionate about this because I do work in the whole spectrum, from the clinic to the hospital, to the nursing home, to death. So I'd like to jump right in. When it comes to Black people, we have data from the United States that at the end of life, many of our Black seniors experience discriminate, excessive, aggressive care in critical care, die in hospital, hooked to all kind of tube, not understanding and also not trusting that palliative care is actually associated with longer life, that doing nothing is not doing nothing, that that palliative care which centers on symptoms. So at the end, so when we're looking at the latter stage of dementia, when a person is often, you know, now in need of help for nutrition, hydration, toileting, transfer, is at higher risk of infection because lying in bed, they develop bed sores. Lying in bed, they're at high risk of aspiration pneumonia because the bacteria from the mouth can travel.
Yeah, absolutely.
There is now a false understanding. So dementia at the end of the disease is really total organ failure. So the brain is like the conductor of the orchestra, such that when that brain is now shriveled and the person is no longer able to initiate feeding, initiate hydration, help with their transfer, using aggressive modes such as tube feeding that has its complication, does not protect for aspiration pneumonia, may be ill-advised, and force the person into an environment that is now foreign and aggressive and inhumane. Furthermore, antibiotics in that setting is not associated with longevity because the protective barriers for infection, protecting the airway, protecting the skin are broken, such that the drugs don't make a difference. So that's when if there had been a conversation earlier on in the journey, closer to the end of life, before end of life comes, that palliative care, which focuses on behavior, for example, there are drugs for that, drugs that can help support the person at the end of their life so that they can remain with their family, so that they can be supported. Pain can be addressed to manage agitation so that we can understand that palliative care is about managing the symptom without necessarily associating it with a date associated with the end of the life. We don't know when we're gonna die. You could be in palliative care for years, but the problem is our healthcare system in Canada has tied access to palliative care resource with the prognosis of less than 3 months. And that can be done with cancer, but it cannot be done with dementia. So again, advocating with policymaker would go alongside to provide better care at the end of life. And I don't want to monopolize the talk.
No, I appreciate that. My father is in a nursing home right now, and everything you said is just, when I talked about, for example, 1.5 million Black people in Canada, over 928,000 are born outside of Canada, and it had me thinking about myself and my friends and people that I know. What is the will? What is the long-term plan? When you ask your parents, how would you like, your aging to be? What's the retirement plan? What's the end of life stage? They would just look at you and say, well, you're my retirement plan. We had you, so that's what you're going to be doing. And as a child, you're like, oh, okay. You don't know anything about it, right? And when you think about, what's the planning for? Should they get sick? What does that mean? What does that say? And the response says, oh, I'll just go back home. You'll just send me back home and I'll age back home. And you're like, I don't even know what that looks like. So having these conversations in a real way can really help mitigate against some of these, I call them traumas, as you go through. Yes, Yvonne, you have your hand up, sorry.
Yeah, there's so many points there that Dr. Norris made that I want to touch on. I feel that we share some of the same concerns, talking about even, I'll just touch quickly, the palliative care piece. I'm West African. I went to Ghana several years ago, and the family there didn't understand what palliative care is. So my certification is in gerontology as a nurse practitioner. I teach it as well, and I teach in a palliative care geriatric program at McEwen. And it's interesting when I talk about my work there that it wasn't understood even what that meant. It was laughed at, actually, going, there's no such thing that exists in our culture. And, again, this is anecdotal. This is one family member telling me this, but it truly was a lack of understanding. And when I spoke to other family there, they didn't see that. It felt like it was just a part of the progression, and you do the best you can. They didn't know that there was services and things that can be connected. And another point, and I don't want to take too much time, is that there is a mistrust of the system too. So once you enter it, do you ever come out of it? I know that a close friend of mine dealing with dementia within their family, access program that may be similar across Canada. It's called a choice program, where seniors can go in and have a whole lot of services: social work, physician access, dietitian. So it's supposed to be comprehensive as well. And it's not necessarily only for seniors with dementia, but it does primarily target that, because it also has respite service. And that was one story that I was going to bring up. This friend had a family member in respite services, but their caregiver visited every day. So the respite was not actually happening, because even though they were at home and had a weekend to be able to recoup their energy, be able to do something for themselves, they spent every day coming to visit their family member because about it. And those reasons they could explain, but what you could see was mostly guilt. It felt that they were disrupting this person's life that they had given up. And also the family member called them pretty much, every hour when they first got there. So I don't know if there's a piece where we also need to do better in terms of the services are there, but we need to also understand the lived experience and the values for the people accessing it, and how they're also supposed to be able to really utilize it. Because one person's experience with having respite is very different than another person's culturally, even as within a subculture as well in that family. But we do know that because of given roles that we have in the Black community for especially female caregivers, she was so worried about the optics of this and putting a parent into a choice program, even though it was a small amount of time. So that's just something to put out there. But the mistrust, to go back to that, has been brought up several times. It's several times in conversations when I've encouraged friends. So many of them are healthcare workers themselves, and they're seeing their families experience things such as dementia, diabetes, hypertension, and advocating for them. Their parents or their loved ones are very concerned about what will happen to them. So that is a big elephant in the room about why people don't access sometimes these services early on.
Wonderful, thank you. I want to go to Rose.
Yes.
Go ahead, Rose.
Yes, I'd just like to also just reiterate the fact that there is great mistrust. And my own personal journey with dementia, with a family member with dementia, we were very reluctant to access long-term care at end of life. But one of the things our parents did many years ago was that they sat down with our family to talk about advanced directives, what they would like to see for their end of life, what kinds of things they wanted. They planned everything that they wanted for their funeral and all of that. And so I guess one of the things I'd like to encourage people to do is try to do that now while you're young. We talk to our children all the time about the things that we want. It's important to do those things while the cognitive ability has not gone impaired, and while the person is able to communicate, and to do that early on. One of the things that we were very concerned, and we were very afraid about placing our mom, was that would she be mistreated? Would her things get taken? Her belongings, personal belongings get taken. All kinds of things we were concerned about in placing. How they at this Black woman. Our mom was a mover, shaker in our community, a woman who loved her community and worked tirelessly to help to elevate the community. And she was a director of the first Black director of a daycare center in our province. She received an honorary doctorate degree from Mount St. Vincent, where she received her education, an honorary doctorate degree. She was in her 80s, And so people in our community who are living with dementia, they deserve to be treated with dignity. At their end of life, they deserve to be considered as someone that they're not a throwaway, that they are important, and that services need to be available for them in the community. We have, thank the Alzheimer's Society of Nova Scotia, we have a Black navigator, health navigator, who is starting to really connect with the surrounding communities in the Preston area and doing some education sessions. There needs to be more of that. government needs to put more funding into this work, because one person cannot cover a whole Black community,
absolutely.
the province and the whole Black community. It's a lot to expect of one person,
Absolutely.
but it's a beginning, and I'm very pleased about that. I just believe that what needs to happen is that I hope that there are government people listening today, because there needs to be funding into research around dementia in the Black community. We need to have researchers who are Black, researchers who are at the advisory board tables to talk about what research needs to be done. We need to be part of not part of the problem, we need to be part of the solution. Absolutely. And one of the things that we say at HOC all the time, not without us. So I believe that we need to be part of we need to be at the policy tables.
Absolutely. Absolutely. Wonderful said. Thank you. Dr. Holloway, and then I'm going to open up for questions to the audience. Go ahead.
Yes, very quickly. I just want to walk it back that in addition to palliative care, for our people from our community residing in long-term care homes, we need to make sure that the staff are educated and oriented to respecting them, providing them the dignity that they deserve, that they have culturally relevant activities, food, acknowledge their spirituality. And I think it was Zena, I think in the chat, she said, we want to make sure we have enough money for when we get old. Let's not go there, folks. We want to have publicly funded healthcare.
Yes.
We need the government to support equity in healthcare. So let's not start talking about we shouldn't have to. We've already been outdone. We've lost so much money that hasn't been given back to us. So we need to advocate. And I want to say, as you said, Rose, we need to have the problem be discussed with us in situ. So we need more of you young people. I'm on the way out now. We need
don't say that. Don't say that, Auntie. No.
More young people to run for government. Thank you.
Yes.
We want you to run for government. You should be running for office. That's what you should be doing. I know the time is at 1:17 and there's so much more we could talk about this. This is why I say we're at the dinner table. But I want us to open up questions to the audience. I just don't know if I should open up now. There is some information I want us to know about the Alzheimer's Society of Canada is doing to support initiatives within the Black community around dementia. There's some really great initiatives that if people want to get involved with us, they can. Just really quickly, we're developing some national guidelines work. National guidelines are going to be used to support family doctors being able to make the diagnosis with their patients living with dementia. And so the Alzheimer's Society is working with the Canadian Canadian College of Family Physicians to develop these guidelines. We are supporting Black and Chinese communities first right now. This is going to be ongoing with other communities, but right now we're supporting Black and Chinese communities. So if you want to be a part of that, please contact myself or the research.ca and to get information about that, to join us as well. For those of you who do have any concerns around dementia for yourself or your loved ones, if you're a healthcare practitioner that wants to know how to better support your clients living with dementia, we do also have an info line. I'm hoping that Leah can drop it in the chat for us. The info line you can call between the hours of 9 and 5, Monday to Friday. We can connect you with your own provincial Alzheimer's Society or regional Alzheimer's Society to provide extra support and materials there. I'll stop there. I want us to open up. I want us to hear from everybody else. If there are any questions burning in people's minds, we can address in the 10 minutes that we have, so we can leave people with a sense of community, a sense of, I don't want to say closure, but maybe beginnings of how to walk this journey a little bit more hopefully, if I can say that. Any questions in the chat right immediately, or the Q&A? There are questions in the Q&A. I don't really know how to do this. Can someone please speak to experiences with Black physicians in Alberta, Canada, and how they tend to deal with individuals presenting symptoms, worse, better, or different? This was asked at 12:49. I want to say we've covered that. Here's a good one. What are the highest priority research questions regarding dementia in Black communities in Canada? That's from Inbal at 1 o'clock. Anyone want to take that? What are the highest priority research questions regarding dementia in Black communities in Canada? Yes.
We need data.
Yes.
We need data. We need race-based data. And this race-based data should address the diversity within our Black community, right? I mean, I'm Francophone, Caribbean, Haiti, French, you know, upper socioeconomic status. It's a very different situation than someone from Nova Scotia. So not only do we need race-based data, but we need within this data the specificities that address our intersectionality.
Yes.
And of course, that requires money. So again, we're going back to policy and back to government. And
absolutely,
I have the energy, but I'm better as part of a team. So anyone wants to be part of a team, that's where you'll find me.
So I will comment on asking about that question that was earlier about Alberta and yes, assessment and whatnot. Not that I do those assessments. So my work is after the diagnosis have been made, or doing screening to pass them along to an expert that will, such as Dr. Norris, to do the actual official diagnosis. But I have a colleague that is an assistant professor at the University of Regina, Dr. Vivian Paplumu. She has been doing research in this area and try to get, not necessarily in dementia, but in older Black adults, trying to increase the visibility and also get that data. So there are people who are out there and researchers that are very invested in looking at what it looks like, because I completely agree with you. I think it was Dr. Holloway who said that we need people to forge forward. We need people in levels of leadership that will put visibility. I'm part of the Geriatric Nurses Association, and I've been fortunate enough to be in a space where I can bring in information that maybe some of the experience is not, it's not visible. It's not there for the people who have traditionally been in these roles. So, and look at things that Ngozi, the access and reach that you have as well. So I think this is starting the conversation, but empowering people to say, what are the boards and committees that we're part of to be able to influence as well. We also have the Africa Center in Alberta as well. So for people who are looking for engagement and support, they do have social services, they have education opportunities. We've connected for them with research, and researchers in the University of Alberta and also MacEwan University have connected with them because they are such a big access, and they are for African diaspora too. So we do have these places, but I agree with all of you that it's not enough. We need to be able to start asking for some of the resources to actually put some hard data out there.
Well, so we have 8 minutes left, and please don't kill me, everyone. I'm so sorry. To Sabrina, you asked a question about organizations specifically for the Black community in regards to dementia and Alzheimer's. For everyone who registered, we will be sending out an email in about a week or so with a list of organizations around the country by province, Black-centered, that support people living with dementia. So please stay tuned for that. Camille has a very good question. She asked at 12:52. It was, we need to speak about prevention, reduction, and modifiable risks, and incite people to take action. Can our panelists speak about how our community can do this, please? I think that's a very practical question, and we can leave people as a takeaway with them, which is basically, how do we modify our risk behavior? What can we do to help ourselves in this case? What can we do individually at day-to-day amongst our families? Dr. Holloway, please go ahead.
So JCAN has already started by having a social connect to seniors. So it's like a couple of hours. It's like a social, because, you know, with the pandemic, everyone was locked in. Of course, being at home, the depression sets in. So we started, and it's very informal, but we make sure that they have discussions, so it makes them involved in the day-to-day things. We have music, we have dancing, which is all to do with the left and right brain. I'm sure Dr. Norris knows more about that than I do. We talk about the events of the week, the day. We have something to eat, and we always have a spiritual piece, because we know that's very important. And this whole group is driven by the seniors. So once again, we need to make sure that we involve the seniors in what we're doing, so that we, you know, we accuse others of not doing that. So let's make a difference, and let's start with that. Thank you.
Wonderful. Rose, and then we're going to close off. Oh, go ahead, Rose.
I want to...
Oh, go ahead. Yes, I wanted to also say that, oh, this is so exciting. You know, we still have so much to share. I wanted to also say that in our community, we have a group called Tea and Chat. And it's a group of primarily people over 60, some a few years younger, but the group talks about whatever topic they decide upon. And it's just a time to get together. All kinds of information comes out of that group. And groups and communities where people feel safe, where they feel that they can come together just to share their concerns. And I think this is a crucial piece of our survival and a part of us staying well and staying whole, that we meet and enjoy one another's company and also learn. That's where our Alzheimer's navigator, Alzheimer's Society navigator, came to present a few times on dementia. And so, you know, groups that are community-based, community-driven, like Dr. Claudette was saying, that are led by community and older people in the community, I think that will be a saving grace for us.
Wonderful, thank you. Dr. Norris, you have the last word before I close out.
Yeah. I just wanted to emphasize the determinants of health. So if you have good health, manage blood pressure, manage diabetes, manage your weight. You know, they say Mediterranean diet, but there is an Afro-Caribbean version, you know, like more fruits, vegetable, nut, olive oil, fish, avoid smoking, avoid alcohol, manage stress, optimize sleep. This is where the brain heals, address hearing loss, vision loss, exercise. All of these are evidence-based ways to prevent dementia. Education, the more you work on your brain, you know, helps improve cognitive reserve.
Thank you.
I agree.
Thank you. I'm losing the time, and I know people have to go back to work. I want to thank our panelists for this discussion. Like, my heart is full. I was teary-eyed halfway through. I was like, oh my goodness, this has been informative. It's been nourishing. I wanted to give us all a sense of community, that we are not in this alone, that we can support and rely and see each other to be able to go through this journey. So thank you for being along with us on this journey. I would like to thank Brain Canada. I would like to thank the research team of the Alzheimer's Society of Canada. I'm naming out people, Cameron, Leah, Anita, Amanda, Saskia, Harito, Santasha, everyone, thank you so much for being a part of this and pulling this all together. Thank you to the audience for joining us, wherever you are on your journey, wherever you are helping others to be on their journey. Bless you and thank you. This is the first of hopefully future conversations we're gonna have. Brain Canada, we have other conversations every month, so stay tuned for that. We're also gonna be having more conversations around other communities, South Asian, Indigenous, East Asian. So stay tuned for that. We're going to make it all, because we all are affected by dementia, and we all want to be on this journey and heal together as a community, all communities together. Thank you everyone for your time, your grace, your patience, your heart, and your understanding. Bless you. Thank you. And we will see you again.